Hello, everybody. YCT and Maharat students and all of our friends in YCT community and interested people who have gathered together for this very somber but important session. I'm a psychiatrist and the director of Pastoral Counseling. I'm Michelle Friedman at YCT Rabbinical School. And as I said, it's my somber honor to moderate this discussion on Jewish values guiding ventilator decision-making between Dr. Ken Prager, who is a renowned pulmonologist and ethicist at Columbia University for over 50 years, and also the president of the YCT board, and our very own Rabbi Jason Weiner, YCT Musmach, and chaplain at Cedars-Sinai in Los Angeles. So the conversation, the discussion is going to be, this is going to be the format of the program. Each of our two speakers will have about 5 to 7 minutes to do a kind of frontal presentation. During that time, and all through the hour and 15 minutes that we're gathering, I ask you to please direct your questions in the chat room to me, and I will sift through them and present them in the discussion section. So welcome everybody, and without any further ado, the order is going to be Dr. Prager and then Rabbi Weiner. Dr. Prager. Unmute yourself.
Oh, pardon?
Yeah, now you're unmuted. Good. Okay.
Oh, okay.
And everybody, please be on mute. Okay.
Yes, as Dr. Friedman said, this is a very somber time. I have been very intensely involved in the last 2 weeks, involved with formulating policies at New York Presbyterian Hospital for the inevitable crunch and the crisis, which is already upon us. So let me just get to the heart of the matter. As you all probably know, I think it's impossible not to be aware of what's been going on. Because of this horrendous pandemic, hospital resources are being stressed as they never have, I think, in American history. I don't think this has ever happened before, certainly not in my 52 years as a physician. And so we are focusing, most of the people focus on ventilators. I think it's perfectly well to focus on that for now. A ventilator is really a symbol of life. When people can no longer breathe on their own and will die without mechanical assistance, we put them on a ventilator, which can keep them alive until hopefully they recover and they can be taken off the ventilator. And what happens when you have more people than you have ventilators? How do you choose who shall live and who shall die? First of all, I should tell you, this is a situation that no doctor ever wants to confront. We do not consider ourselves, despite all the jokes, as godlike. We would like to help everybody, even people that really have no significant chance of survival. We don't like to be put in that circumstance, but we are. So the question is how to deal with that. And there are two ways, basically, when the need for ventilators exceeds supply. Either you can say, we will do this on a first come, first served basis. Whoever is here first, no matter how sick, no matter how likely or unlikely they will survive, putting them on a ventilator, first come, first serve. And that takes away the ethical challenges for the physicians. Or you can say, we have this scarce resource and our goal is to save as many lives as possible, even if it means withholding or even withdrawing life support in some of our patients in order to enable the most people to live. And this is a philosophical approach called Utilitarianism. You probably have heard that term as well. And so most healthcare providers, not all, feel that this is an ethically appropriate approach. The utilitarian one, where we will try to save as many lives as possible. So I will give you just a quick rundown of the basic structure of the type of policies that have been constructed in order to make this effective. Number one, patients are assessed in terms of what their medical characteristics are and what the prognosis for survival is. And if you have a patient that it is unanimously agreed by physicians, this patient has little to no chance of surviving, even with the ventilator, even with ICU, then the guidelines would say that person should not be put on a ventilator because somebody who could survive with the ventilator will be deprived. And that way 2 people will die instead of perhaps 1. Instead of just the 1 person who is hopelessly ill dying, we will have the person who might have been helped and might live, they will not get a ventilator. Clearly, in this kind of schema, you have to be reasonably sure that your diagnostic criteria are correct. If your prognostic criteria are not fact-based and not correct, you may deprive somebody of a ventilator who might have lived. So that's very critically important right there. Who should make that decision? Most of these schemas say it should not be made by the doctor facing the patient. That responsibility should be given to a committee, so a triage committee or a health resource allocation committee who don't know the patient, cannot show favoritism, who will simply look at the bare medical facts. They will know the age of the patient, the sex of the patient, and they will know the medical facts. And they will make a decision based on scoring criteria as to whether or not this patient would benefit from a ventilator and intensive care unit treatment. That decision then, if it is negative and the patient is withheld from the life support, that is relayed to the family. It is based on, as I say, objective criteria. And this is not something that we burden the physician who is facing the patient to make that known to the family. It's obviously a tragic and a very sensitive kind of an issue. I would make also a point that's important. I think the decision to withhold a ventilator is infinitely, well, I wouldn't say infinitely easier, but is somewhat easier than withdrawing. Saying to somebody and to a family, we do not think that your loved one will be helped by this ventilator. We feel they are too sick to benefit from it, and we will not offer it because we are limited and we must save lives of people who are salvageable, is easier emotionally and perhaps ethically than saying this patient is not getting better, is already on a ventilator, but because the patient is much worse, their prognosis for survival is minimal, we will remove the ventilator, resulting in almost the immediate death of the patient. That is infinitely harder, but it is actually incorporated into some of these triage plans. So that is a very short presentation. Obviously, the devil is in the details, and we'll have plenty of time to discuss that. I would just raise a couple of ethical issues that there's no right or wrong answer. In the allocation of a scarce resource of a ventilator, should preference be given to the healthcare workers? Should they be in that dire circumstance? They have put their lives on the line. Should they be given preferential treatment? And should the criteria for putting them on a ventilator be lax, more lax than for other people? Should age enter into it? Does age, is that reasonable to invoke? What about quality of life situations? If you have somebody who is in a vegetative state or in a coma, but who is medically stable, is that a quality of life that we think is so poor that even though that patient medically might survive, we feel that it's inappropriate to place that patient on a ventilator who has no consciousness, is not aware of their surroundings, and deprive somebody who is with it and aware of the ventilator. And one last point, and that is, even if we agree that even if we agree on the ethical appropriateness of the particular plan that I just outlined, will doctors have legal protection if they withhold or withdraw support? I can tell you in New York State, if I today were to withhold a ventilator from a patient whose family wanted me to put them on a ventilator, I would be in violation of the New York State Family Healthcare Decisions Act, and I could conceivably be sued for malpractice and even possibly for a criminal violation. So without legal protection, these plans will not go into effect. The legal protection may vary from state to state. Something may be ethical but illegal, and something may be unethical and legal. And I will stop at that.
Thank you very much, Dr. Prager. I know that I've been getting messages before Rabbi Weiner starts that we have reached our max on Zoom, and people are being directed to the Facebook page who want to live stream it. It is being recorded and will be available later, but apparently we have reached our max on Zoom. But you can also access this through Facebook. So now I'm going to invite Rabbi Weiner to speak from his perspective. Please unmute yourself, and the floor is.
Okay, thank you. Hello, everybody. So I want to share some thoughts based on halakha, based on Jewish values, with a couple caveats, just obviously pointing out that, our hospitals, even Jewish hospitals, like the hospital that I am the chaplain for here in Los Angeles, we function on, well-accepted secular standards, it's not based primarily on Jewish law. And also, what I'm going to share with you are my suggestions, my thoughts on the matter. The poskim that I've reached out to at this time have not quite had the time to kind of confirm or reject what I've said. They've given me some guidance, but I take responsibility for what I'm about to say, and it's just suggestions. It's not meant as a conclusion or a psak, halakha, or anything like that. It's just some Jewish values in triage. So the first point that I would make is that obviously the first thing that has to happen is very careful triaging. I have here, it's probably easier if I share the screen, but just you can see this. This is a basic triage algorithm that I often use like when I'm teaching students. This I got from a hospital. This is used not in pandemics, but it's a basic triage algorithm. And basically what you have in this algorithm is, priority 1, priority 2, and priority 3. And this is for someone walking into an emergency room. If they're walking, they're already delayed priority. Number 3, the lowest priority. They're gonna have to wait at least a few hours. If they're walking but not breathing, they might end up in priority 2, where they're gonna be seen sooner. But if they're not walking, they're gonna likely be in priority 1, where they'll be seen immediately. And this algorithm, the 1, 2, and 3, is basically the sickest patients, the most critical patients are seen immediately. The intermediate patients will be seen soon, and the patients who can wait will wait. And when it comes to emergency triage and pandemic triage in halakhic sources, and you have many in Israel, many of the poskim in Israel who write about this because they've had to face these issues when it's come to different types of tragic situations there, have expressed a slightly different approach. And it's similar to what Dr. Prager outlined. It's basically what I phrase as the Hatzalat Harabim approach, the attempt to treat the most people possible. So for example, some sources, because I'm trying to present like some Jewish perspective. I'm sure many of you are familiar with the ethical dilemma of trolleyology, right? Where the person is standing by a train track and the train's barreling down the tracks, and you see that it's going to hit a family of 6 who's having a picnic on the track. And you have the choice, you're there, you happen to be right at the fork in the track, and you can pull a lever to divert the train to another track. But then you realize there's someone taking a nap, one person on the other track. And if you pull the lever, your action will kill that one person. But should you save the 6 and kill one, or just do nothing and allow sheval tase passively to kill the 6? So interestingly, a number of the poskim who write about this quote the Chazon Ish. The Chazon Ish has a similar question actually in his treatment. And he argues that his treatment is actually about an arrow, the arrow that's been shot. The Gemara references an arrow being shot at 6 people, and somehow they have the ability to kill all 6, and you have a shield where you can divert the arrow and kill one. And he says, if you divert that arrow and kill that one, it's not an act of murder by killing the one. It's an act of saving. It's not a Maisa Hariga, it's a Maisa Hatzala. So you might say, I'm killing one, but no, you're saving 6. Rav Zilberstein, who writes about this, he writes, it's similar to like, imagine 2 boats, capsized, and you could only save one of them. But one boat has 20 people, the other boat has 5 people. So obviously you save the one with the 5. So the goal is prioritizing the highest number of people. And this perspective will actually change the scoring. So in this chart that I showed you where there was 1, 2, and 3, and number 1 is the sickest patient, they get seen the soonest. This perspective might actually say number 2, the second category, the Beinoni, what we would call in halakha, the intermediate, gets top priority. The people who will require the least amount of resources, they need the interventions, but they will take the least amount of staff time and resources. So if you have one person who's deathly ill, God forbid, and to save that person's life, they're going to require an ICU room, a respirator, respiratory, technicians, nurses, doctors. They're going to require quite a bit of intensive care. But you also know that you have 3 other people who, in that time that it will take you to care for that one person, you could treat all 3 of those people with that staff, with those resources. So the poskim write that we actually should favor the intermediately ill. They quote, for example, there's a Mishnah Brura about a house that's burning. and people have to run into the house risking their lives to try to save people, and they have a choice. Save a person who's deathly ill from their injuries from the fire, or a person who's moderately injured. And the Mishnah Berurah actually says, save the moderately injured individual, because you now have opportunity to save their life and then hopefully more lives. So this is a perspective where we're trying to save as many people as possible. Obviously, we're prioritizing, we're triaging people with the better chance of survival. The poskim discuss people with the opportunity for chaye olam versus chaye shah, the chance to live a full lifespan versus someone who's terminal. Many of the poskim are troubled by the possibility of basing these triage decisions on age, and they say it should be on clinically relevant health information of the patient, not just their age. And then obviously, as Dr. Prager mentioned, if it's possible to allow someone to die, meaning not to cause it, but allow it to die, whether that means allowing blood pressure medication to run out or allowing IV interventions to run out rather than withdrawing actively, then obviously that should be prioritized than active removal of interventions. But this leads to, and this is the main thing that I want to just focus on for a couple of minutes before I wrap up, the most difficult question and the most controversial question, which is, would halakha in such situations ever allow active removal of interventions? So what we would call, and I'm going to refer to with respirators, but this might refer to also dialysis, especially continuous dialysis or other types of interventions. Would we allow terminal extubation? Could someone be removed from their respirator in such a way that they will die as a result for the sake of these triage decisions? Now, normally, at least I'm just talking from my own perspective, normally we say that terminal extubation, such that a patient will die fairly immediately as a result, is prohibited by Jewish law, because we are concerned that it's what we call a grama. It's a causative, it's causing their death. Even if it's not killing them, it's causing their death. And even though we might be lenient sometimes with a grama, when it comes to Hilchos Shabbos, when it comes to nezikin, damages, we are much more cautious, and we don't want to even cause someone to die. And since this is potentially murder, that's the language that some of the rabbis use, that terminal extubation is murder, we're careful and we say, you know what, we better not extubate. However, there is another perspective that I want to share, just to throw out the idea and explain why I'm throwing out this idea. It's based on a Ramah. The Ramah in Shulchan Aruch in Yoreh Shin Lamed Tes says the following. In fact, I'm going to read it to you because we should all be familiar with this to make this decision, because I'm going to just share it with you for you to decide, and sharing with you that many rabbis do not agree with this. So I'm not saying that this is what we should be following. I'm just saying, for the sake of discussion, we should think about this and then approach our rabbis if we were ever, God forbid, filling out an advance directive or making such a decision. So the Ramah says as follows, and I think it's important to read it. It says as follows: you cannot cause someone to die faster. That's prohibited by Jewish law, to speed someone's dying process. Kagon, for example, Mishu goses zman aruch v'lo yuchal liparei. Someone is a goses for a long time and their soul can't leave. The rabbis say that, based on this, that when a person's soul is trying to leave their body, it's painful when it's stuck in the body. It's pain. It causes pain to the soul to force it to stay in its body. So, for example, the Ramah says, you cannot remove a pillow from under their head, because they believe that certain goose feathers cause the person's soul to stay, and if you would remove the feathers, you would cause them to die. Or, you can't move the patient, because we believe that someone who's in the dying process is like a flickering flame. And if you move them, you could cause the flame to go out and they will die. You can also can't put the keys to the shul under their head, because they believe that would cause them to die faster. So all these actions that make someone die faster are completely forbidden. We can never cause someone to die faster. Aval, however, here's the main line. If there's something that's preventing the soul from leaving, something external, something that's preventing the soul from leaving, kagon, like there is a sound, someone, a rhythm, let's say, or a noise of a wood chopper that's chopping wood, or or there's salt on the tongue. And the Beis Lechem Yehuda, one of the commentaries, said the salt was put there to keep them alive. And then they realized, oh, that was a mistake. We shouldn't put the salt there. Let's remove it now to allow death. And these are preventing the soul from leaving. Mutar lahasiro misham. That can be removed Why? Because this is not an action. It's removing the impediment. So in other words, it's not causing to die. This is the important distinction. It's not causing to die. It's allowing the person to die. And so even though we would never say in halakha, kill one person to save another life. We can't even say kill one person to save a whole community. But perhaps one could make the argument that this is not killing one person, it's allowing them to die. I'll give you an example that we have in medicine. One of the things that we have is, in the modern world, total artificial hearts. There are people who are waiting for a heart transplant who their heart failure is so severe that they cannot wait long enough to get a new heart, that they need to have their heart literally removed and replaced by a plastic machine that becomes their heart. One of the ethical dilemmas we face as a result of that, though, is can you ever turn that off? What if they become no longer a candidate for a heart transplant? They get strokes, they get infections. Can you ever turn that heart off? Turning that heart off literally is turning the person off. It kills them instantaneously. So the question is a respirator the same? The respirator is not replacing the the lungs. The respirator is helping the lungs function. It's doing the function of the lungs. Once you remove the respirator, you allow the person to rely on their lungs, and they most likely will not survive in many cases. But could it be different? I could see how someone would say turning off the artificial heart is killing, but is removing the respirator killing or allowing to die? Now, normally we say, well, if it's maybe killing, so I don't want to maybe kill someone. I don't want to take a chance of accidentally or maybe having killed someone. But what if the case is, well, it's maybe killing someone or maybe it's allowing to die? And if it's allowing to die, then I can save many more lives. Now we start to have a real dilemma. And in fact, Zalman Nehemiah Goldberg wrote a tshuva. This is going way back tonight. I forgot the year. It was in the early 80s, I believe, the late 70s, when he wrote this. And he argued this, based on this Ramah, that if the person's going to die anyways, you can allow them to die as long as it's not instantaneous, as long as they wouldn't die the moment they are extubated, but you can allow someone to die for the sake of others. Now, not everyone agreed with him. In fact, many disagreed with him. And I actually asked him about this a couple of years ago. And he told me, look, everyone disagreed with me, so it's just, the halakha v'lo l'maisa. It was just in theory, but not in practice. But my question is, in a real, triage situation, could we possibly rely on this? And this is my question for rabbis. In fact, in searching this past week, I did come across in the Sefer Asya, a volume from 1997, Tafshin Nun Zayin. They quote Rav Shlomo Zalman Auerbach as follows. Regarding a respirator, it's up to the doctor. If the majority say that this respirator is no longer helping that patient, it's better to remove this respirator to someone else. He's then careful to point out, and I would be foolish not to put his say how he concludes that I'm not putting down halakhic nails in halakha. This is a difficult question, and there's not clear proof from the Talmud and from the rabbis about what's the right thing to do. So I'm not saying for sure, but he seems to accept the possibility. And in general, I don't say that if it could save more lives, we should end someone's life. I do not say this. I have trouble. I'll just say as a very quick side point with organ donation when it comes to DCD organ donation, which is where they remove a respirator in order to allow someone to die faster in order to save their lives. I still think there's halakhic problems with that. But in this case, when it's a crisis and there's a chance of allowing many people to die, we have we're pulled in both ways. And on the one hand, we have lo talmud adam riyacha. All these people waiting for a respirator, we say, lo talmud adam riyacha, you can't allow people to die. And Rav Zalman Nehemiah Goldberg's argument is that when someone is in the dying process, there's no prohibition or no requirement of lo talmud adam riyacha. When they're in so bad that it's tov mosi mechayai, from Yonah, when Yonah wanted to die, when he says, my death will be better than my life. If someone's life is so bad that they're in the process of dying, their illness is so bad that they'd rather be dead than alive, then there's no requirement to save their life. But there is a requirement to save these other people's lives who are waiting for a respirator. So this leaves us, and I'll conclude with this could resolve, three kind of dilemmas that weigh on me, even though I'm of the perspective that normally it is forbidden by halakha to remove a respirator from someone who will die shortly thereafter. We struggle with a few things. First of all, I always say to people, my line to families, always based on halakha, based on Igros Moshe, or Moshe Feinstein, is we do everything we can to prolong life, but we do nothing to prolong suffering. We don't want to prolong the dying process. And we have to figure out when we are prolonging life and when we are actually just prolonging suffering. And unfortunately, if we never allow terminal extubation, especially in these cases, we can find ourselves where we're not only not saving lives, and at the same time, we're prolonging suffering and prolonging the dying process. Furthermore, if we say that we can never withdraw a respirator, we can never extubate, then there will be many patients who will say, you know what, because I'm not sure that I'll be able to extubate, I'm not going to intubate. I'm not going to try to save their life in the first place. And there's patients who theoretically we could have saved, but we said, well, I better not, just because I know I'm not going to be able to take it off later, so I'm not going to put it on now. But if we say, you know what, there are ways that we could take in certain situations, limited situations, we might be able to, so why not then? Let's try to save a life. And also, I believe that we have this strong value of Hatzalat Harabim, trying to save as many lives as possible. So of course we have, and I'm proud of the fact that Halakha says, Ein dochin nefesh mipnei nefesh. That's true. But there's a dilemma. We don't value any life more than the other life. It doesn't matter how utilitarian one person is to society and how someone is treated. You know, we value all human life. Who says whose blood is redder? And I'm proud of that we have that in Halakha. And at the same time, we have this dilemma though, because we want to save as many lives as possible. Hatzalat Harabim. So we're stuck with that. But if we would allow in certain cases terminal extubation, in cases where the person is tov mostly mechayim, they'd rather be dead than alive, and they're suffering, we're prolonging the suffering, and they're in the dying process anyways, and it's allowing them to die, not causing them to die, then maybe we could be able to fulfill both mitzvahs. The mitzvah of not that we're giving one life to the other life, but that we are allowing people to die comfortably, and we are also focusing on saving as many lives as possible. This needs to be approved by postgame. I'm just suggesting it. This is not still right now. I would not want to terminally extubate somebody. I would feel horrible about it, but for the sake of discussion, it's worth, exploring these ideas.
Thank you so much, Rabbi Weiner. Before I go to the questions, and we have some superb questions and I'm sure speak to the whole group, I want to ask Dr. Prager, is there anything in what Rabbi Weiner said that you would like to respond to before we get to the questions?
Yes, I'd like to point out one very important issue. Rabbi Weiner has very eloquently stated the circumstances in which, even according to halakha, removing an impediment to death is permitted, both for reasons of humanity for the person who is dying to prevent their suffering. The issue that we get into now with this whole ventilator allocation, if the patient is willing and agrees not to go on a ventilator, or even if a patient is willing or the family is willing to say, you may extubate my father, mother, brother, sister, they are hopelessly ill, we give you permission to do so, that's not a problem. The question is, these triage policies speak about doing this without consent. And that is an issue. I don't know how halakha would approach that, but we are talking about potentially not putting somebody on a ventilator against the wishes of the family that say, I don't care how desperately ill you think my father is or whether he'll survive or not, we want him on a ventilator. Or the worst case scenario of taking somebody off the ventilator to save somebody else, where the family would say, I don't care, you have an obligation to continue to treat my loved one, we are not giving you permission. And these triage policies are calling for unilateral withholding or withdrawing of life support for the greater good of saving more lives. And that's the crunch, that's the ethical conundrum. When there's consent, that's not an issue. The question is, when there is not consent, should doctors ever be given that right? I don't know if halakha addresses that particular subject.
Rabbi Weiner, do you want to respond to that before I go to the questions from the chat room?
Sure. I mean, I agree. I think that's a huge concern. That's a concern of mine as well. That's my.
We're in a new territory that it's uncharted. I'm going to switch for a moment. I've gotten a lot of questions, and I don't think we'll have time for too many more than have already been sent in. But I want to switch a little bit, and we're going to come back to more sort of medically framed questions. But this is one that people have asked me actually in advance of this session. about the impact on the patient, the family, and the medical staff of making these decisions. So somebody wrote in, when my mother was in critical care in the hospital, there were no chaplains or social workers making rounds and no visitors permitted into the hospital. We've all heard of these stories of people dying alone, resulting in additional trauma to the patient and family, and certainly the staff. How do hospitals make sure, well, we can't make sure, but how can we provide spiritual and emotional care to all of these people, patients, family, and staff in this traumatic time? So suggestions, you two are right there in the thick of it. What's your wisdom here?
Well, I can speak for Columbia. I think the question is absolutely a critical one. The amount of moral distress that is experienced by doctors and nurses, not to speak of the families, is enormous. It's absolutely enormous. What we're trying to do at Columbia is to involve our palliative care physicians and nurse practitioners as much as possible with speaking to families about goals of care discussions, about calling families up. We have actually just today, we have started a palliative care inpatient unit where patients who are not on ventilators, where families have agreed and the patients have agreed to be allowed to die peacefully, they are in these units. The problem, of course, is the visitation. Here we are balancing the tremendous emotional need to be with your loved one when they are dying versus the potential harm of spreading the virus and causing more healthcare workers to become sick and more patients to become sick. And in that situation, we favor not having visitors because of the greater harm that we feel that is being done to the entire system of having people come in who may spread the virus. So we try to address this. We have pastoral care, making calls to family. We use FaceTime whenever possible so that they can see their loved one if the loved one can't communicate. We have to deal with the moral distress of the physicians. I can tell you that part of the moral distress is not just withholding ventilatory support or possibly taking somebody off a ventilator. There is moral distress when somebody who is near death and the family insists on aggressive treatment, and there's moral distress by the physicians who know that somebody else might be harmed by that ventilator going to that particular patient. Or if that patient has a cardiac arrest and the family wants full resuscitation, the healthcare workers are being exposed to the potential of being infected because CPR involves aerosolation of the virus. They are exposing themselves to a potentially lethal virus in the process of doing a futile intervention. Think about the moral distress in that. And these people have families as well. They go home to their wives and husbands and kids and so forth. How do you feel after you have done CPR on 3 people one morning, all of whom had no chance of surviving the CPR, but the families insisted on it, and you were exposed and had to be exposed unnecessarily to the risk of becoming infected. So we try to do, I can tell you that when I get calls from house officers, I try to become a little bit of a psychiatrist as well, acknowledging their moral distress, telling them how much of a hero they are to be in the thick of the battle and doing all of this that they are for humanity, and trying to have them share some of their emotional distress with me while giving them, while trying to give them advice on how to handle the situation at hand. But the moral distress is huge, and we're doing our best to deal with it.
Thank you so much. And Rabbi Weiner, can you please speak to this from your, from your stance at Cedars-Sinai and your role?
Yeah, I mean, it's very similar, almost exactly the same. And we're trying to proactively reach out to families by phone. We're proactively trying to support the staff, whether it's bringing them meals and little gifts and putting up notes and doing everything we can to support the staff and be there for the family and kind of be an intermediary for the family who can't enter the hospital. And exactly like Dr. Prager said, it's the moral distress is devastating.
So I'm going to move to another question, which has to do with really making choices. And the person wrote in the issue of giving medical personnel priority for ventilators. If someone was that sick, they would not be likely to be able to return to work for weeks and weeks. So should they be given priority, the frontline soldiers in the field, or should they be triaged the same way as everybody else?
Well, we have addressed that. This is a real contentious topic, and I'll give you both sides of the issue. On the one hand, one can say, you doctors are making up these priority lists. It's not fair that you're putting yourself in a favorable position by saying that healthcare workers should receive priority. That's not fair. You have a vested interest, obviously, in being as healthy and staying alive. So that's not right. And look, you went into this medical profession. You realized that you might someday be treating patients with contagious disease. Firemen face risks going into a burning house, and policemen face risks, and people in the military who join up, they know that their lives are endangered. So why should you get preferential treatment? On the other hand, one could say, in terms of this issue of returning to work, I don't think the answer to that is that any healthcare worker who ends up on a ventilator will not be able to return to work. This epidemic may go on for months, and it is entirely conceivable that some of these survivors, if they are healthcare workers, will in fact be able to return to work. And not only that, they will be immune, as far as we know, from the disease. So they will be in a circumstance where they will be very unlikely to become sick again and could be put in more precarious situations. So the return to work, I think, is a potential argument in favor of that. The other thing is, you can look at it and say, well, you knew what you were getting into. On the other hand, is there a certain amount of justice in saying, you see the lives of some of these people, some of the nurses and doctors who have to come home every single day, strip, take showers, have to hose down everything so that they can go back in their homes. They don't sleep in the same room as their partners and so forth. Shouldn't we acknowledge that by perhaps giving them a little bit of an uplift when it comes to prioritization? It doesn't mean getting rid of all criteria, but if you have two people, hypothetically, who equally might deserve that ventilator, giving priority to the healthcare worker. And number three, I would say that the morale of the healthcare workers can sag at times, and they are putting themselves in risk, and they are exhausted. And for them to know that if crunch time ever came, they might be given a little bit of a tip in terms of access to health, to a life-saving intervention, it might be a tremendous boost to their morale. I'm not giving you the right answer. I'm giving you the pros and cons, and you can decide for yourselves.
Rabbi Weiner.
Yeah, I would just point out that there is support that can be found for that approach in Halakha. The approach that I tried to outline of the Hatzalat HaRabim, saving the masses, many of the poskim write that there can be an individual that is in the category of Rabim Tzrichim Lo, a person that's needed by many, many people, and that can impact their priority. So there is such a concept in Halakha.
Okay, so I'm going to kind of continuing with this theme. This is something everybody can see. What are the ethics of healthcare workers being asked to volunteer to serve on COVID wards and facilities that can't provide or don't provide or whatever adequate PPE, personal protective equipment, for those people who are not yet familiar with that acronym? Why don't you stay with this, Rabbi Weiner?
Yeah, so I mean, I think it's the classic risk question. We always weigh, the benefit versus the risk. And generally the approach we take, it's kind of like similar to organ donation. The approach we take based on the Radvaz, there's a lot of sources that are related. First of all, we know that we do have Rabbi Akiva's statement, Chayecha Kodmim, you have to save your life first. Though there is the story in the Talmud Yerushalmi of Rav Amy, who was captured by bandits, and the rabbi said, okay, I guess just prepare his burial shrouds because we're not going to be able to save him. And Reish Lakish says, no, I'm going to risk my life and kill or be killed to save him. And there's this big debate, which side do we follow? And generally we follow the side that our life comes first and we don't risk ourselves if it's that high of a risk. But the Radvaz was asked if someone should be willing to cut off their arm. If they were told by the government, this was in 15th century Egypt, let us cut off your arm or else we'll kill another Jew. We'll kill someone else. And he asked the rabbi, do I have to give my arm to save someone else's life? And the Radvaz basically said, if you will likely die, if it's a very serious likelihood of your death as a result, you may not do it. It would be a chassid shota, you'd be a pious fool risk your life that severely. If there's very low risk, I mean, let's say if it was a case where there was minimal risk, but you could do a lot of good and save life, then you can. It would be a great thing. It could be a mitzvah to do it. If it's in the middle category, which is where I think we might be with this type of a case, where you could do a lot of good, but you're putting yourself at some risk, you are allowed to take upon that risk, but not required to by halakha.
Thank you. There are many questions coming in about the medical aspects, and I'll get to those. But I do want to read one out that came in much earlier and is really kind of on a more philosophic level. And the person writes, and I'd like to understand why people who in general oppose utilitarian approaches to ethics, because utilitarianism doesn't show sufficient respect for the dignity and worth of each individual human being, seem ready to endorse utilitarianism in a time of pandemic. What is it exactly that legitimates this shift? I understand and share, the writer puts in, the frantic sense that we have to share to save as many lives as possible. But I wonder about an approach that embraces a more philosophic approach in that we usually reject that. Was that clear to people?
Sort of. My understanding is of the question, the questioner seems to be saying that under normal circumstances we reject utilitarianism.
Yes.
I don't know that I accept that. I think in general, we do try to do the most good for the most number of people. I don't know that necessarily derogates the sanctity of the individual human life. What about all the individuals who might be saved? What about the sanctity of their lives in terms of the greater sanctity, if you will, in numbers? So I'm not sure that there is, in general, we are fortunate in this wealthy country that the principles of utilitarianism rarely have to come to the fore because we have enough ventilators and hospital beds and ICU beds. Where it does come to the fore, I can tell you, is in organ allocation.
Right.
And even in times in the pre-COVID era, in normal times, we do employ the principle of utilitarianism. We say we will not waste an organ. We have this one heart to give, and 3 people we may reject because we think that they will die even with the provision of the heart. And so we're going to give it to the person who is most likely to benefit from it. So I don't know that there is that great a gulf between how we think philosophically before and during this epidemic. I think now it's brought to the fore because rarely do we ever have to triage ventilators the way we do now.
Right. I would add that this is a softer utilitarianism in a certain way. Like, for example, one of the common cases of utilitarianism in medical ethics is, imagine a physician comes into his or her clinic, sees their first patient, and says, wow, you have a perfect bill of health, just, you have heart failure. Other than that, you're perfect. You need a heart transplant to live. Next patient, you're a perfect bill of health, but you have lung failure. If it wasn't for your lung failure, you'd be fine, but you need a lung transplant to live. Next patient, you're perfect health, but you have kidney failure. If it wouldn't be for that, next patient, you have liver failure. So on the 5th patient, the doctor goes to and says, wow, you're in perfect health. You're perfect. The doctor's about to leave for the day and says, gosh, 4 out of 5 of my patients are going to die. What a bad day. And then says, oh, you know what? Why don't I just take that 5th patient who has the same blood type? It's perfect. I'll kill that 5th patient and then give their organs to the other 4 and save their lives. So I think we would all say that would be horrendous, right? Like, you can't just kill someone. So that would be a utilitarianism that we are not advocating here. What I was even suggesting, if you would call that utilitarianism with the possibility of withdrawal from one patient to save the many, is only when you could categorize it as not killing that one. So if you have someone who's dying and you can allow them to die, I don't see that as the same type of utilitarianism, even though there is utilitarian ethos involved with that, but it's softer. It's not just utilitarianism. There's guards on it.
Yeah, can I just follow up with what Rabbi Weiner said? I agree with that 100%. I think it has to be made clear we are not sacrificing people who might well survive in order to save somebody else. We are withholding or withdrawing life-prolonging treatment from people that by our best clinical judgment and criteria, we feel are hopelessly ill, no matter how aggressively we treat them with ventilators, with ICU, with pressors and antibiotics, that they're going to die anyway. Are we 100% correct all the time? Of course not. Of course not. But we use, and we have these committees, and it has to be the unanimous judgment of the committee when we're making, if we're going to make a decision like that. But I think it's important for everybody to realize we feel that these people are hopelessly ill, and it would be an ethical wrong to allow somebody who might be saved not to get the life-saving treatment from somebody in whom that life-saving treatment will not preserve their life. That's the issue.
So I think this is a perfect segue to a question that everybody can read, which is, do statistics play a role, any role in halakha, or should they, or it? It seems more and more data is becoming available about outcomes of people of different ages, pre-existing conditions, etc., who are receiving ventilator treatment or candidates for ventilator treatment. What about intubating a patient of whom it is assumed that they'll need longer ventilator time than another? How do we use data that is rapidly becoming compiled, hopefully, to make these halakhic and moral decisions?
Yes, I think data is critical. In fact, I don't remember if I said it. I wrote out these protocols. I think we forgot to send it out. Anyone can see there. I posted them on my website, rabbiweiner.com, W-E-I-N-E-R, if people want to look up these protocols. And in halakha, there is, suffix versus vada. You save the person that has better chances. That Ravaz that I mentioned, talks about 50% chance of survival versus less than 50%. So I do think that part of, and I'm curious to hear Dr. Prager's more, detailed response, but in halakha, there's certainly a discussion of likelihood and chances as part of the decision-making process.
Yeah, I would just say that the longer we get into this COVID crisis, the more data that we collect, the more precise I think we will be able to be in terms of prognostication. One thing I think is already clear to physicians, and that is that people who are on ventilators in COVID, they don't get better in a week or two. They may need up to 3 weeks to get better. And so using a criterion of, well, the patient's not better after a week on a ventilator, maybe it's time to remove the ventilator, I think that would be medically and ethically very, very suspect. The more we understand about the natural course of this disease, the more ethical our decisions can be. My mantra is, and all of my students who have ever taken a course with me know this, I always say the ethics flow from the facts. The better and more accurate our medical facts are, the easier it is to make an appropriate ethical judgment, and the more ethical it turns out to be. And we're in the process of collecting all this data now and applying it. I can tell you every week we have a pulmonary conference where we discuss the latest research, the latest clinical findings, and we try to apply that immediately to our patients.
Thank you very much. Another question that was asked earlier, there's been talk, we've all seen this, about having patients share ventilators, which is a complex medical operation given that the settings need to match between the two patients. So Dr. Prager, can you say a little bit about how hospitals are discussing this and how do the ethics figure into this?
I can tell you a lot about it because our hospital was the first anywhere, I think, to actually carry out a trial of doing this. As a matter of fact, the ethics committee at Columbia was consulted by the physicians who wanted to have a trial of using 2 patients on 1 ventilator, whether this was ethical or not. We had a long late night discussion about the risks and the benefits of doing this. There are certain risks to it. Patients have to be paralyzed in order so that they can synchronize adequately on the ventilator. We felt that although this was, shall we say, an expedited trial, normally we would go through probably a much longer period of vetting this out. But given the fact that there was this imperative need to maximize the use of ventilators, we were actually given a mandate by the state to try to carry this out. We drew up an informed consent form that was given to the relatives of the patients who might be in this protocol, because they basically had very little, if anything, to gain from this, and they might be potential risks. Is it ethical to go ahead and do this? And in fact, we got informed consent from all of the patients who undertook this trial. And so far, it seems to be that there is a protocol that might be employed. It would have to be employed in certain restricted circumstances by very skilled people. But this is knowledge that may end up saving lives. I don't think on a very large scale, but given the crunch that we have now on ventilators, and if this can be disseminated based on the experience at Columbia, then lives might be saved.
Rabbi Weiner, any thoughts on this?
No, I don't have experience with the sharing ventilators.
Okay. Okay. So then I'm going to go to something else that's been asked about, and that has to do with, again, Rabbi Weiner, actually, this might be more directed to you first, which has to do with halakhic issues. People can see this question. Does the consent of the family have a halakhic impact for ventilator withdrawal before death? And I would put together with that, what about people who write in, and we're not going to have time to explain this. I'm assuming the audience is very familiar with the difference between advanced care directives and a healthcare proxy, but people who have spelled this out themselves. So advanced care discussion, which has hopefully been given over to a healthcare proxy, communicated to that person that somebody does not want to be put on a ventilator, or the consent of the family. How does that weigh in halachically?
Well, in Halakha, it's actually a very similar discussion that happens in medical ethics world. There's a big debate between, should the primary concern be substituted judgment, meaning the family is doing their best that they can to say what that patient would say, could they speak? Or do we invoke a best interest standard where we just simply say, well, here's what I think is best for you, and this is what I'm going to decide on your behalf. And the halakhic approach, at least for adults, not for children, but the halakhic approach is that we favor the substituted judgment approach, where the goal of the family has to be obviously in accordance with halakha, but the goal is to advocate for what the patient themselves would say they want, not what we want for them.
Okay. Dr. Prager?
Yeah, no, I think I'll tell you where we get into problems. When the advanced directives of the patient and the substituted judgment of the proxies are in sync, all is well and good. But what happens if we have an executed advanced directive of a patient that says, I do not want to be resuscitated, and the time comes and the family says, I want you to ignore what my mother said. We want her to live as long as possible. Ignore that. We want her to have CPR and go on a ventilator. What do we do in that case? Now, I can tell you from legally, the advanced directive generally trumps what the family says. If we ignore the advanced directive, then what's the point of having advanced directives if it can be overruled once the patient loses capacity? On the other hand, I can tell you that a physician standing at the bedside when a patient is about to arrest with the DNR in his or her hand and the family saying, I don't want you to listen to this. Don't you dare let my mother die. It is the unusual doctor who will ignore the wishes of the family. And generally speaking, in a situation like that, the patient's wishes will be overridden because of the emotional impact of allowing somebody to die against the wishes of family. I think there may be times when it's appropriate to override a DNR, when the DNR might have been executed under circumstances that no longer apply, or when the patient was severely depressed. And in the present circumstance, attempting resuscitation makes ethical and medical sense. But in general, our ideal is to carry out what patients want.
Okay. I want to invite people to send in. We have time, I think, for a few more questions. And I also wonder if Dr. Prager and Rabbi Weiner, you might speak a little bit from your bedside or ethics session side experience of things that have been just to sort of maybe touched off, not from these questions, but in this last hour that you have come to mind that you would like to speak about.
Okay, well, I can tell you, as I've said before, this is an unprecedented situation. It's unprecedented, and I hope it won't happen ever again, although I guess these things happen every 100 years or so. The stress that we talked about before on the physicians, the patients, the families is incredible. The other day, we had 10 patients on respirators in the emergency department of one of the Columbia affiliated hospitals. 10 patients, not in an ICU, but in an emergency room. This is, so you're dealing with imminent life and death situations that have to be made like this. I think, speaking on behalf of my colleagues in the medical profession, and I know these young doctors who are dealing with this, they're wonderful people. These are heroic people. They are not looking, they are trying to do this as ethically appropriate as possible. They are looking for guidance. A lot of people think a negative stereotype of doctors that, you know, playing God and we know everything and so forth. I'm not saying that there aren't doctors like that, but the doctors that I know and the efforts that they are putting in now to be fair, to do the right thing in life and death decisions has to be applauded. They really, really want to do the right thing. On the other hand, it really does hurt them very much when they have to do things that by law they must, which they think are inappropriate, unethical, like attempting resuscitation of somebody who is halachically a goses. They are moribund. There is no chance. And exposing themselves unnecessarily to this risk and to potentially their families and so forth. So, some of these things I hope will be worked out in the coming days. I hope sooner rather than later, because all the statistics point to an even greater crunch on hospital beds and on ventilators. I hope that we will give them the authority to make decisions which, after appropriate vetting, they think is ethically and medically correct. But this is the situation that we're in, and it's an ongoing process. I don't know what's going to happen during the month of April. I can tell people that at least in our hospital, we afford people the opportunity to get as much medical and ethical guidance as possible, the people in the trenches, so that they can make the right decisions. And we try our very best to afford emotional help and succor to the families and to the patients as well. But this is a very, very stressful time.
You know, Rabbi Weiner, before you comment, I want to just point to another question or comment that just came in that I think might inform your response as well. And you spoke about this, Dr. Prager. What happens when your own personal halakhic, personal and halakhic or halakhic ethics contradicts the patient's or their family's request? And you've just spoken about this, Dr. Prager, but Rabbi Weiner, when you could you please, in your comments, you know, add to that as well?
Yeah, that's an important and difficult question that's very common, unfortunately. And, you know, first of all, we need to advocate for everyone's right for conscientious objection. If a medical professional feels that there's something that they can't engage in because it troubles them too much, they should have the right to object and to withdraw themselves from the situation. And, you know, this is one of the things we're trying to do, is to provide as much support as possible so that people have someone to talk to and reflect these ideas by. This is the importance of ethics committees like Dr. Prager's, and I know ours as well, that are, you know, proactively reaching out to people to be available to them before these issues even arise, to kind of talk about what they're comfortable with and what they're not comfortable with. It's a halakhic issue as well. You know, lifnei iver and misayea, there's concerns about aiding and abetting with things that we find to be troubling, though there is a lot of room for flexibility there as well. It really depends case by case. You know, I've really been impressed, you know, this is an important question. I've been impressed by not just the sadness of the moral dilemmas and the moral trauma being inflicted on many people, whether it's staff or families of patients, but also on the desire of so many to do good, to help others. The staff who have been saying, you know, send me to the COVID floor, send me to the front lines. I want to help. I want to make a difference. This is why I went into medicine. Of communities, we're overwhelmed literally with people bringing meals, catered meals for nursing units and staff, and donating blood. And I mean, the outpouring of chesed and kindness and giving of people, of oneself, whether it's medical professionals, community, Jewish organizations and beyond, it's really been inspiring. It's really beautiful. It's part of the positive legacy of what we're experiencing.
And I think we all have to go to that. You know, we have to go to, I've been doing these talks about mental health and how to how to strengthen. And I think going to the good, like, can I, in this discussion, quote Mr. Rogers, look for the helpers, and think about the good that's being done. I want to switch to another topic, which is so important. And thank you to the person who wrote it. Can you comment on the problem for doctors, staff, and patients of deciding the risk-benefit relationship of going into hospitals for non-COVID related illnesses, risk of exposure to infection versus risk of not getting needed care? I mean, all through this crisis, which we know might last, we don't know how long, people are having heart attacks and they have their cancer treatments and they are awaiting all sorts of, okay, we're not talking about really elective types of things that can wait, but medical life goes on and people have non-COVID crises that they are very scared. I mean, I know of, cases where people let a UTI go and it went, a urinary tract infection became a severe kidney infection because the person was frightened to go to the hospital.
Well, I think my answer to that would be yes. I think that there's a triage system going on right now in terms of who goes into a hospital, period. We're trying to overcome this, or trying to do the best we can in this circumstance by having what you've heard of telemedicine or phone calls. A number of doctors many doctors, I should say, who are not trained to be able to treat people in the ICU, people of subspecialties that they're not skilled enough to do this. And I can name a whole list of specialties. So they can help out by taking phone calls, by administering. Somebody with a urinary tract infection, of course, can be treated over the phone, and they can have people call in and get antibiotics. So we are trying our best. And I have patients. I still have an active practice in addition to the ethics work that I'm doing every day. I have phone calls to make to my patients, and I try in every circumstance to keep them out of the hospital. And I would be doing things that I wouldn't ordinarily do. I would want to see them in the office. But balancing the risk of infection, going in the emergency room, etc., versus the lesser risks of being treated by phone, we tend to choose the latter. I'll give you just one other example. An outstanding thoracic surgeon, he emailed me this morning. He's the head of our lung surgery department, and he generally does lung transplants. He does lung cancer operations. And by the way, these are being deferred now, and people's health is being harmed. So if you have a cancer that needs to come out, but you're not imminently in danger, chances are your surgery is going to be deferred. And while it's being deferred, might it metastasize and might you lose an opportunity of cure? Yes, you might. But these are the realities that we're doing now. That's why I'm saying triaging on an even larger level is occurring right now. But he wrote me and saying he's taking in quote unquote an internship on how to be an ICU doctor. We even if the ventilators are in supply, we have a shortage of nurses and doctors and rooms to staff the people who need it. So we are recruiting chest surgeons now to be intensivists, and we're trying to recruit other people in other specialties. That's how serious the situation is. But I think what Rabbi Weiner said, I want to underscore, and I'm so glad he brought it up, that it's bringing out the best in most people. Yes, you hear an occasional inappropriate action by a doctor or people ordering a whole bunch of Plaquenil pills so they could store enough for themselves and their family. But this is grossly outnumbered by the outpouring of doctors who are frustrated. I want to be able to help any way possible. Older doctors, myself in that category, are being told not to come into the hospital. The Mayo Clinic, Yale University, Mount Sinai in Florida, among other hospitals, are prohibiting doctors above the age of 70 from coming in because they feel the risk to the physicians is too great, and these physicians can be doing worthwhile work from their offices or from their homes.
Rabbi Weiner, would you like to add more?
I don't have anything to add to that. That was well said.
Okay. All right, we have a few more moments, and there's sort of a two-part question here, which has to do again with judgment of who gets preferential treatment, about triage decisions, on saving, a question of physical and mental disability, on how triage decisions are based on saving a maximum number of lives. If people have fewer pre-existing conditions, should they have the benefit of intubation? And would that exclude disabled people, disabled in all categories? What does Halakha say about this? And the question continues, if the argument is made that physically, and I would add perhaps mentally disabled people should be attempted to be saved even if needing longer ventilator care, doesn't this suggest that their lives matter more than other people?
I can answer medically, and I'll let Rabbi Weiner address it halachically. I can tell you this is a very sensitive issue. And some of you may know that the Washington State, which is where the COVID crisis broke out even before New York City, the Washington State was sued because of their guidelines by the disability community, saying that they were being discriminated against. And this is obviously a very sensitive issue. So ideally, I would think, and I'm speaking for myself, but I think many physicians feel this way, of course, a person who has a disability or a handicap should not in any way be discriminated against when it comes to life-saving interventions. I'll just tell you, there was an op-ed piece in the Wall Street Journal last Friday, which I actually happen to have it right here, because rationing care is a surrender to death. This was I thought, an awful article because it misconstrued the rationing policies, going to the point of even saying, will people who are blind be deprived of ventilators? That's outrageous. That's absolutely wrong. And it puts this fear, this seed in the populace at large, saying, if you've got a disability or a handicap, forget it, you're going to be, that's not true. If you have a handicap or a disability that will significantly decrease the likelihood that you will survive, even with intensive care, that is a relevant factor, just as it's a relevant factor if you have severe heart failure or if you have severe COPD and you have this COVID pneumonia. If the likelihood that somebody with horrendous emphysema will not get a ventilator because the physicians feel there's no way this patient is going to be saved, are we discriminating against people who have emphysema? Or are we saying we are using the ventilator appropriately for people who can live? So similarly, there might be a situation where a person with a particular physical disability, where that might impact significantly on their survivability, but only in that way would that be a relevant issue. We're not talking about, and the other thing is, we're not talking about quality of life. Somebody with intellectual disability, that life is equally valuable as the person who is a Rosh Yeshiva or person who's a president of his corporation. We don't say this life is better or more valuable than another one. We try to make this fair, and only insofar as your ability to be saved with this scarce resource, that is how we apply these guidelines.
Thank you. Rabbi Weiner?
Yes, absolutely. I agree 100%. That's the halakhic approach. That's why I was trying to emphasize before, the concept of mi yomar de dami didach suach tzvei. We have this principle of who says whose blood is redder, and that's why we have ein dochin nefesh mivnei nefesh. Normally, you can never give one life for another life. We believe and are proud of the fact that all human life is an image of God, and all human life has equal value, and no one should be treated preferentially because of intellectual or physical disabilities. It should not impact their, they should not lose out because of that in any way. The only factors the poskim take into account are, one that I mentioned is the ability to live if someone's terminal versus someone who is not terminal. So clinically relevant health data, or if they have a better chance of survival. But exactly as Dr. Prager said, only health data, not the person's, physical or mental capacities. I agree that would be morally repugnant.
Thank you. We have a few more minutes, and I think it's time really to close. And I want to give each of you a moment to reflect on, a last sentence or two that you want to leave our listeners with. And, as you just think about that for a moment, I really just want to say how proud I am of the YCT Maharat community, of our chairman of the board, of our Musmach, Dr. Weiner. Chairman of the board is obviously, Rabbi Weiner and Dr. Prager. And thank you so much for this time, for the effort. I know how emotional and powerful it is to be talking about this and to be explaining these difficult concepts in ways that are available and compassionate. And I think that has been so much the tone of this session, is your learned compassion. So in the spirit of that, I'll go in the order that we started, and I'll invite Dr. Prager to say a few closing words, and then Rabbi Weiner.
Okay, well, just some final thoughts. This too shall pass. This too shall pass. We will get through this. It will take months. It will be hard. We have survived as a society and as a world crises that are equally or greater severity. You know, how we behave as a society, I think, how we behave as a profession will be engraved on history. And I hope that as a society, we will rise to the occasion. We will mobilize all of our resources to try and to provide as many healthcare interventions, ventilators, ICU beds as possible, so we will not be in a position of having to ration. And I can tell you we're trying very, very hard right now. I think I can speak on behalf of the medical community. Thus far, I am very proud to be called a doctor, because I am proud of what my colleagues are doing all across the country, how they are endangering their lives and rising to the occasion. And so I look forward to the light at the end of the tunnel, when we can look back and say, it was a horrible tragedy. We lost so many people. There were lives lost, but we did the best we could under incredible circumstances. And as a society and as a medical profession, we did our best, and we can be proud.
Thank you. Rabbi Weiner?
I feel like I keep on agreeing with Dr. Prager. We should have had some more places where we could disagree, but I would just echo, I mean, first of all, thank you, Dr. Friedman. It's very comforting just being in your presence virtually. You're my teacher, and you know, it's just great having you here at this difficult time. You know, as you said that, it's funny, as Dr. Friedman, as you said, you know, what's your reflections? And I'm sure Dr. Prager can relate, and probably much more than me. Because I've been asked this question a few times in these types of meetings in the last few days. And the first thing that comes to my mind is, you know, I haven't had time to reflect yet. There hasn't been, we're still in the middle of it. Like, I don't know, I haven't reflected. And all I can really say is we're all doing our best. I mean, what we presented here today was very difficult, you know, really hard, you know, gray area questions. There's no clear right or wrong. It's like, we're just trying our best. And it's so inspiring to see everyone gathering together, asking very good questions, challenges, suggestions, and that, you know, that's what we're in it together. We're in it together, trying to figure out the right thing to do. And it's a beautiful thing to sit down for a minute and just think about what's the right thing to do in this situation, and to recognize people are suffering, and people are working hard on their behalf and doing everything they can. And, you know, I'll just end with a prayer. May God bless us all, and may we all just know good health. May those who are sick recover. May the families who are lonely and isolated find support and sustenance during this time. May this Passover be a time of redemption for all of us, for all of humanity. And maybe, like Dr. Prager said, look back on this and be able to be proud that we did our best. And hopefully we get through this as well as possible. And may God just bless all of us and the entire world at this time.
Amen.
Amen. Thank you, everybody. And with leadership like yours and guidance, there's a light at the end of the tunnel. Thank you. Chag Sameach to all, and may we reconvene on happy occasions.
Amen.
Amen.
Okay, we're going to end the meeting now. Thank you, everybody.